we still have to be very careful about the pandemic, because it's physical health and mental health are related. All right, I've had my booster, so I feel safe. All my children and my grandchildren all caught COVID except me and my wife, and we are considered a high risk one. The ones that can actually get a fourth shot booster. So I also urge all of you, those of you who are above 50, not many governments can do this, right, to give you your vaccination, which by all counts is a form of medicine. So unless you don't believe in medicine, please get your jabs. All right, I share with you a little bit about the hospital. I was told to share about the what we do in IMH, and I just wanted to start off by saying that we're the only tertiary psychiatric institute. Is it working? Oh, okay. Yeah, and Singapore is not that big. So for 5 to 6 million population, we probably only need one tertiary center. But a tertiary center will see at most 10% of all the mental health disorders or the diseases that we have under this scope. We currently employ about 95 psychiatrists, and we have just around 180 doctors in the hospital. Total staff of about 2,500. 1,200 are nurses, and then we have allied health administrators, ancillary staff to support the hospital. Now, just to give you a sense of scale, IMH sits on a ground that is about 22 hectares, all right, which is like 22 football fields. Those of you are football manic, you understand. The old hospital, built in 1928, has a size of about 145 hectares. So we've shrunken by 5 times. But we are still the same size as the Singapore General Hospital, Singapore's largest hospital, physical hospital. They do have a psychiatric department, and one of the psychiatrists is here. Is Leslie still here? Oh, he's gone off. Yeah, so I just give you a sense of sizing. SGH, on the other hand, has about 20,000 staff. All right, IMH has 2,500. Right. In terms of overall budget, okay, the Institute of Mental Health operates at around $300 million a year. The Singapore General Hospital probably more than $1 billion in operating. Okay, so you must understand the scale, and then yes, IMH has grown over the years. We are almost 100 years old. Next year we celebrate 95 years of our existence. Now, why do I start with the, whoops, you moved the slides already. You can go back a bit. Okay, why do I start with this picture? You might think, wow, very nice and scenic. This actually is the picture of the hospital that I put out what I call a concept plan. So a concept plan is a 50 to 100-year-old plan for the hospital. The hospital is like this tree, and in our strategic planning in the last 20 years, we've been talking about the tree. The tree consists of 3 branches. Each branch has a part of the work that we do for Woodbridge Hospital Stroke Institute of Mental Health. We have a clinical service, we have a research, and we have education. The clinical services are focused on mentally ill, means people with mental illness, which today is about 13.9% of the population probably have a mental illness of some sort. That translates to about 600,000 to 700,000 people. 10% who are severe are seeing us. So we see about 50,000 patients, unique head counts that are under our care. There are other psychiatric hospitals. They're not psychiatric hospitals. They're hospitals with psychiatric departments in Singapore. All the general hospitals have that. We also have private hospitals that do this. The other branch is research and education. A lot of people don't realize that IMH does a lot of that. The education is mental health education. So we train all the psychiatrists. We have about 270 plus psychiatrists in Singapore, and probably around a little smaller, I think, number of clinical psychologists, although overall the people who are psychologists may be larger. And then we have occupational therapists, social workers, and other therapists who are in the system, and a lot of them come to IMH for training, including the nurses, right? And we are so all nurses will do a rotation through IMH, and then there's also psychiatric nursing, which is a kind of subcategory. And then we have research. We do a lot of research that informs the government on policies. Like, for example, I told you the prevalence. The prevalence of mental illness in Singapore, 1 in 7, is based on an IMH study, the Singapore Mental Health Study. We've done 2 tranches of that, 2010 and 2016, and that's the numbers that we have. And at the base of the tree is the roots of the tree, and this tree has got 3 roots. Previously, we call it our finance, our processes and branding, and our manpower roots. We changed it a little bit. Moving forward, we focus a lot more on what we call the smart hospital, the hospital that can do a lot of work, that's automated so that we don't need so many staff. Then we have instead of just finance, we look at quality of work, so we call it value-based care. And then finally, good people. We need good people to work at the hospital. Just as a side issue, mental health professionals are not the most popular profession for people to take on. For doctors in particular, for a long time, whenever I go to a medical student group and I say, who wants to be a psychiatrist? Everybody, I don't know whether it's true of pastors, but pastors is the spiritual alternative of a psychiatrist, in case you don't realize that. So we rely on you as well. Okay, so that's IMH and our history. Now, along this, you can see this nice mountain, right? This is not working. Which button do I press? Okay.
Oh, it is.
It is it? Okay, it's slow, is it? Okay, so just imagine by the river that this tree grows is a river. It's called the River of Life. And on this River of Life, we have what we call living well, living with illness, crisis care, and living well. And you can see strategically placed IMH is at crisis care because we are a wooden bridge across this river at this point. Now, if you understand rivers got different parts. The beginning of a river, near its source or at the upstream level, the waters are generally very calm. Then it gets faster and faster as it goes down. And further down, there's a lot of small mini waterfalls. The waters are very rapid. And that's why people drown. So the River of Life, and this metaphor is not mine, it's described by a lot of social scientists, that people fall in the river and then when they go down, they are drowning. And we are saving the people who are drowning. But we've been doing that for many years. People who have illness, then they come to us. What we want to do is to probably go upstream to deal with people who are not doing so badly but have risks. For example, you had a traumatic event. There is a risk to you. If you have a young child who has been sexually abused, what are the risks of that person over time developing a mental illness? It's more increased. If you have a parent who has a mental illness, the child's risk of developing mental illness is about 10%. So these are risks that if we can identify, we can go upstream and do work. But further upstream to this is really the concept that we're trying to get there. It's the source of the River of Life. And I know I use the word River of Life as though I'm talking in spiritual terms. This is not done in spiritual terms, but we can take it from a spiritual perspective. The source of the River of Life, for healthcare at least, is that we have good mental health, which is a sense of well-being, as well as no mental illness. That definition is WHO's definition, World Health Organization definition. So if you think about it, well-being is actually a health what we should be aspiring to in healthcare. And in a way, there is a spiritual dimension to this. And I hope we get to talk about this later on. That even in health and illness, there is a spiritual dimension because it's about well-being. It's broad, okay? And promoting mental health cannot be just done by doctors and clinicians in general. And we're trying to do that. We're trying to identify what are the things, how can we keep moving? Okay, what are the sources of health? Okay, I just wanted to show you that this was our logo. So this is what we are trying to aspire for the next 50 to 100 years. That's the River of Life, and the one is a rainbow of 7 colors. I think rainbow has always been associated with the gay, lesbian, LGBT movement, but you need to reclaim the rainbow, okay? The rainbow is God's covenant
Amen.
For us, yeah? Right? So that rainbow is the 7 aspirations that we have in our hospital to bring our patients from crisis mode only, hopefully to go upstream, and to go to the source to prevent illness and promote health. So that's our broad concept plan. But let me give you more in terms of details. All right, so tertiary hospital, these are the numbers that we see. Like I said, about 50,000 people we take care of. The visits to our clinics, about 484, and the number of admissions is about 23 on a daily basis. It doesn't look like a lot, but what's happening now is that a lot of people are coming to the hospital because maybe there's greater awareness, there's greater literacy, and everybody says, okay, you got a mental health problem, go to IMH. And what used to be that, we were very stigmatized and people didn't really want to come to IMH, it has changed, right? We have a lot of VIPs who want to come to IMH. They want to see the psychiatrist. Because we have like 1/3 of the psychiatrists are in IMH. And so they come to our doors. So although we admit only 23, we actually see at one point in the pandemic, like 100 people in our E-room. Our emergency service actually, if you've been to the hospital, is very small. It was never designed to hold so many people because our numbers were like this. But that's one part, the acute side. Then we have actually long-term care. See, for a long time, IMH has been having patients in our hospital that nobody wants. We used to have patients who are called unknowns. I mean, literally their name. If you talk to the patient, he says, my name is unknown. Unknown what? Unknown Chinese, unknown Malay, unknown Indian. They actually have that. We have changed that. We have, give them a name. But they were abandoned. They were the least in our society, and they were just put in IMH. We've changed a little bit of that. So some of the destitute, we actually have a destitute home, but most of them were our former patients. The destitute home, by the way, is just outside IMH. It's called Pelangi Village. So that's run by the Ministry of Social Services. And just next to it, the Pelangi Village, is this home called the Singapore Leprosy Home. That's also in IMH's grounds. And you know leprosy, right? Even in biblical times, leprosy was the thing that society puts aside. And that's IMH. We are the put aside place. Okay, so a little detail about some of the services. We have emergency services, which is 24 hours. We have an observation ward. We have a short stay unit, 30-bedded. This allows us, this is newly open. In fact, you're hearing this, the press has talked a little bit about it, and a minister is going to talk about it as well when he comes for nursing, Nurses Day soon. 72 hours of intensive monitoring. So this short stay unit is really for the mental health needs. But we don't think this is sufficient because everyone seems to want to come to IMH to stay, and we have very little residential help. So in some ways, maybe we can talk about it later, is how can the church help in some of this? Then we have a high dependency unit. This is like the ICU or IMH, all right, where we have about 10 beds, where we treat highly suicidal or severely aggressive people. If you've been to IMH, I always tell people, we actually have shields, It's the only hospital where you find a shield. Last time it used to be a rattan shield, but now it's a plastic shield because it's to protect the staff should the patient become extremely aggressive. And it's used by the police actually for, like riots and all that, but that's the kind of things that we sometimes have in our hospital. Now, what are the current mental health challenges that are important? One is aging population. The other is the shortage of manpower. Even though I told you we're 2,500 staff, it's very hard to get staff. Nurses, 50% of them are actually foreigners who come and work here. Very few people want to do psychiatric work. So again, something to think about, and maybe, I believe that quite a number of our staff are Christians because they want to be of help and in an area that is sometimes quite stigmatized. But we need more manpower. And then the healthcare system is changing. We used to be funded just on block budget, but the government is moving towards what is called capitated funding. I don't know whether it's an advantage or disadvantage, but this healthcare system does mean that there are some changes that will be afoot in terms of funding. And then our patient load, of course, is rising rapidly. Remember, if 13.9% of the population having a lifetime risk of developing mental illness and 600,000 people, they all cannot drop in the IMH. We cannot manage, right? Where can they go? Next slide. I just asked next slide, I think it's easier. Okay, so we have tried to do a kind of an improved care model where we try to empanel patients by their location so that there's one team looking after them and that we have one care plan to look after each of their needs. Next slide. And we started to change our clinical departments into what we call subspecialty departments. So there are 6 of them. which are subspecialties. We have addiction, mood anxiety, psychosis. Developmental psychiatry used to be called child psychiatry, but this one has an element of adult work. So like if you have a special need when you grow up, you continue to be supported by that department. And then we have geriatric psychiatry and forensic psychiatry. Next slide. And then these are the regional services that we provide. And so we have departments that are, you can see it's multidisciplinary, led by what we call regional chiefs. And we have 4 regions, but into 3 chiefs. So there'll be a central and north, and then east and west. All right? And again, this is the idea of creating a holistic tertiary service for the whole country. Next slide. And then we also have this group, we call it recovery care. Joseph is here, he supports this recovery care program, and this department looks after the long-term patients. They have 2 roles. The recovery care is, on the one hand, it's like a community hospital, but IMH is both an acute hospital, a community hospital, and a long-term facility. So the long-term facility and the community hospital is under this department, and they look after those who can recover and go home. We will say community hospital. Those who stay with us for a long time, this is the group. So we have a few. One of them, of course, is the elderly, severe dementia, very hard to manage at home. End-of-life care, these are long-term patients who lived for 40 years in IMH. We actually have a memorial service every year for our patients because nobody comes and claims them, and we are essentially, so we get, the eulogy is read by a staff, and then very often only the staff attend. If we can find friends, we're very happy. And maybe we should invite churches to come and help us run this memorial service, take turns, different religions maybe, But we have this end-of-life care that is important. And then we have intellectual disability. Actually, although we are not intellectual disability homes, we have the worst of the intellectually disabled in Singapore that nobody wants. They are here with us. We have about 200 plus to 300, I think. Then we have this group, we call it maintenance. They're institutionalized. It's very hard to get them to go out. They stay in the hospital, they are stable, but they're here. And this recovery care group is growing old, and they have a lot of medical problems. We did a study. If you have mental illness and you're in the community, your life expectancy is shorter than the ones we have in recovery care because we take good care of their physical health. Yeah. But I don't know, they live longer. Yeah. Then we have some community programs. This is part of what we call National Mental Health Blueprint programs. The programs REACH, EPIP, SWAP, CHAT, there are a lot of acronyms. They basically represent, one group is for the young and the the working adults, and they provide services that allow you to stay in, that means for the schools, for example, there is a team that goes to the schools and help the schools manage, identify problems early, and even treat on site. So last time when I was, I'm a child psychiatrist, so I used to see a lot of school refusal, I used to see selective mutism. All of this is now managed by the community. They don't come to the clinic anymore. And that's what we probably need to in our services moving into the future. They stay out in the community. Then we have the CHAT and SWAP programs for for assessment in the community. They are anonymous, so people who feel very shy. And one of the big problems in mental health is this social stigma. A lot of people who develop mental illnesses choose not to seek help until very late and delayed. We've improved that with awareness and literacy training, but still a lot of work needs to be done. And then, so they can go to these programs. MCATS is for the elderly, again, to pick up dementia as quickly as possible. And then what IMH does is we don't treat dementia as a whole, we treat dementia with behavioral problems and psychological problems. So it's problematic dementia. And then finally, we have CMHT and Job Club and the Mental Health GP Partnership. These are community programs for adults that help them find jobs to work with our GPs. Our GP partnership has about 100 plus to 200 GPs who are our partners, and they will manage sort of stable mental health patients. I think that's the last of my slide. Yeah, sorry, I took longer than time. Thank you. Yeah, okay.